You mentioned earlier that you work in a community clinic offering a pain service. Can you tell us a bit about the kind of work you do in the community clinic?
So my role within the clinic is to review patients who have been taking medicines very often for many years. And we look at the effectiveness of those medicines. In many cases, patients will say that actually they are providing relatively little benefit, or are quite a phrase that is very often used is take the edge off their symptoms, which really is a sign that they are not doing what both the patient and we as healthcare professionals would like the medicine to do. And very much around having a discussion around how their medicines are impacting both on their pain, but also their life more generally. And also then having a discussion around other approaches that they may wish to consider in managing their pain, such as improving their skills in self-management, and also looking at other approaches, such as a more psychologically based approach as opposed to simple medicines.
And do things like yoga and Pilates have a role here?
Activity can range from simple chair-based activity or and movement within one's daily routine, but then it may extend to activities such as yoga, as you have just described, but also as individuals become more confident in their own abilities, maybe going to the gym to do light exercise or swimming. And there is such a range of activities, and it is really down to the individual as to what they're going to feel most comfortable doing.
Can you talk to us now a bit about opioid use disorder? How much of a problem is it really in the UK, and how should we tackle it without throwing the baby out with the bathwater, as it were?
I think the first thing to say is that opioid use disorder is a relatively new term that was introduced in the DSM-5 classification of illnesses, and really describes problematic opioid use, and that may be associated either with illicit substances or prescribed medicines, and that it is associated with significant distress and impairment of activities. Obviously, the majority of people I see are taking prescribed medicines, and it is relatively unusual for me to see people who are taking illicit opioids. And it is, however, there are a sizable proportion of patients who one would describe are certainly dependent upon their opioids. However, whether they fit all of the diagnostic criteria for opioid use disorder, I think could be very much debated. Saying that, I think that the main has not really been possible yet in the UK to quantify the scale of opioid use disorder related to prescription opioids. However, the main ways to deal with it are really to consider that initial prescription very much as an opioid trial, and if after a period of 4 to 6 weeks the opioid is not providing any benefit, then that is the time to consider tapering and discontinuing, rather than letting the prescription go on to repeat, and patients then taking for many months and sometimes even years without a great deal of benefit.
Could you just clarify, are we talking about medicines prescribed here for chronic pain or medicines prescribed for post-operative pain?
Most evidence initially related to opioids for chronic pain. However, as you have alluded to, there is a very defined group of people who may be discharged from hospital with a supply of opioids, and in many cases, these patients were not actually taking opioids prior to their procedure. So they are a very discrete group of individuals. But in answer to your question, it is both.
So would it be fair to say that the key messages here are education and monitoring?
Exactly. And so considering initiation, and then regular review once patients have started taking opioids.